Diabetes Connections is brought to you by OneDrop, created for people with diabetes by people who have diabetes. By Gvoke HypoPen, the first pre-mixed auto-injector for very low blood sugar. And by Dexcom. Take control of your diabetes and live life to the fullest with Dexcom.
This is Diabetes Connections with Stacey Simms. This week, catching up with Medtronic. We're talking about the newly approved 770G, looking ahead to the 780G, their acquisition of InPen, and how they think they've cracked the code on longer wear pump insets.
There are things that are in insulin to keep it from going bad. The preservatives, if you will, are behind a lot of the sort of site reactions that you get. So we're able to take that stuff out and have just filtered insulin, if you will, delivered to the site. And that's really the magic behind getting the extension of use.
That's Sean Salmon. He heads up Medtronic's diabetes group. In innovations this week, a once-a-week basal insulin. How would that even work? This podcast is not intended as medical advice. If you have those kinds of questions, please contact your healthcare provider. Welcome to another week of the show. I am so glad to have you. If you are new, welcome. Glad you found us. We aim to educate and inspire about type 1 diabetes by sharing stories of connection. My son was diagnosed right before he turned 2 back in 2006, and we have his high school sophomore 504 meeting this week. Yeah, it's virtual. His whole school is virtual. I've shared on the show before, he is part of a very large school district in the Charlotte, North Carolina area. And the whole district has been virtual. Younger kids are starting to go back to school in October. They're staggering it. But right now, high school won't go back in person until January. At least that's the plan. So I'm really interested to see how they handle this 504 meeting. He's had one. We've been diagnosed since he was 2, so he's always had one. In our district, we have a separate DMMP, a diabetes medical management plan. And that covers a lot of the basics that are maybe in your child's 504. But I assume this will focus on testing. I don't know. I mean, he's home. So, he can go to the bathroom when he wants. He can drink water when he wants. I'll share more about that, though. Mostly, I think this is about keeping our place in the 504 for things like the ACT and the PSAT and all that testing. And he's so thrilled that it's going to be coming up. Another thing I want to tell you about real quick is, hey, in September, we saw a big boost of sales of the audiobook of The World's Worst Diabetes Mom. This is my book. It's part memoir, part advice, stories, real life stories about raising a child with type 1 diabetes. And the Audible version has been very popular. And I'm telling you, September, I don't know, everybody ended summer and decided to get an audiobook, but Audible loves when that happens. And now I have 2 free copies to give away. You do not need to have an Audible account. You don't even need to really start one here. You're not going to be signing up for something you can't get out of. You do need an Amazon account. So if you want the copy, I'm not doing a fancy contest on social media. I probably should, but all you have to do, email me, Stacey@diabetes-connections.com. Put audiobook in the subject line, and I will give the first 2 people who do so a free book. We'll make it very simple there. If you're interested in perhaps the paperback or the ebook, you can head on over to diabetes-connections.com, or it's on Amazon, whatever's easiest for you. One more thing, and it's an apology. Last week, I apparently mixed up when I was talking about Medtronic's 770 and 780G. We do clarify that in the interview here with Sean Salmon, but to be clear, the 770G was recently approved in the US. It is basically the same as the 670G, except for the addition of Bluetooth connectivity for data sharing and remote monitoring. And as you will hear, you'll be able to update the 770G and future Medtronic pumps at home, just like your phone. All right, Sean Salmon with that and a bunch more. We go down a laundry list. But first, Diabetes Connections is brought to you by OneDrop. And I spoke to the people at OneDrop. I was really impressed at how much they get diabetes. And it makes sense when you think about it. Their CEO, Jeff, was diagnosed with type 1 as an adult. OneDrop is for people with diabetes by people with diabetes. And the people at OneDrop work relentlessly to remove all barriers between you and the care you need. Get 24/7 coaching support in your app and unlimited supplies delivered. No prescriptions or insurance required. Their beautiful, sleek meter fits in perfectly with the rest of your life. They'll also send you test strips with a strip plan that actually makes sense for how much you actually check. OneDrop, diabetes care delivered. Learn more, go to diabetes-connections.com and click on the OneDrop logo. My guest this week is Medtronic's Executive Vice President and Group President for the Diabetes Group, Sean Salmon. And we spoke just as the deal for Medtronic to buy Companion Medical, makers of the InPen, was closing. So that is a done deal now. And the InPen is a smart insulin pen. You're probably familiar with it. It keeps track of dosing and recommended dosing, sort of like what you'd get with an insulin pump. You still have to inject, but the dosing can be automatic. The app will tell you exactly what to do and keep track, just like an insulin pump does as well. We talk about that and a lot more here. Here's my talk with Sean Salmon. Sean, thank you so much for joining me. There's a lot going on at Medtronic these days. I appreciate you spending some time with me and my listeners.
That's my pleasure. I appreciate the opportunity. Thanks, Stacey.
We're going to go down pretty much a laundry list of technology and questions from listeners and things that they want to know. But let me start slow and just ask you, how are you feeling about everything these days? We've got delays because of COVID. We've got, a year like no other. It's a cliche at this point. But, in your own words, how are things these days at Medtronic and in terms of, what you're looking at going forward?
Well, it's interesting, right? I think we're all living through some unprecedented times just everywhere in the world right now. And it's certainly challenging. But at the same time, across Medtronic, I think we've got such a rich pipeline in just about every single business. It's exciting to see what the future is going to bring when we get past some of these near-term challenges. I've been here for 17 years, and I can't remember a time where we had so much innovation all stacked up, ready to go.
Well, let's jump in and talk about it. One of the first things I want to ask you about is the acquisition of Companion Medical. And this is the startup. They've got the InPen. This is I think my listeners are very familiar with it. We've done episodes on it. So tell me a little bit about what the plan is for Companion's InPen product with Medtronic. What are you going to do with it?
Yeah, sure. Well, maybe I'll start out with, why did we decide this was a good idea? And, as I came into this role, whenever you start a new job, it's been about a year for me now. The first thing you do is you formulate a strategy. How are you going to serve your patients in the market? And it's really, strategy is really a question of what are you providing for who? When you start answering those questions, it really narrows down what your focus should be in. And it didn't take that long to sort of peel apart what is it that our people living with diabetes are seeking, and how are they being treated today? And you look around the world, it depends on the country you're in, but multiple daily injections is the most frequently chosen therapy. It ranges between 60 and 90% of the treatments that are out there. So, really the philosophy we have is that for us to know what we're providing for whom, we need to know, where are they on their journey and where do they want to go? So, injection in and of itself is a fine therapy, but there's just really variable outcomes that patients are being able to get from that. And a lot of it's really about it's made difficult by the fact that you really don't always know how vigilant you are, how much insulin you've taken, how much you have on board. It's very hard to keep track of all that. And what Companion has done with the InPen system, of course, is to track that insulin so you know exactly how much is given at the right amount of time and have some estimation for carbohydrates, the ability to load that up. And then, of course, the CGM data is there. So when you have those components, a lot of that difficult math calculation about how much insulin do I need to take at a given time is made simpler. And we can extend that by adding a lot of what we have within our automated insulin delivery systems, algorithms, personalization of those algorithms into that experience with a pen. So if you will, we're trying to close that open loop, or at least close it down some. And what we do with automated insulin delivery systems is we have this track record, right, of you just recording CGM data over time and knowing what the insulin amount is. You can really get to an understanding of how an individual is going to respond to insulin and more personalize the amount of dosing that happens. So get an even tighter connection to how much insulin someone needs to take at a given point of time. And of course, on meal handling, that's a place we're really pushing a lot of our technology. We have a very large and capable group that does data science and artificial intelligence. And all that really means is that we're able to take large data sets and then put them into actionable insights that really simplify how people can get better control without having to do anything. And one of the really interesting areas we're investing in right now is around meal handling. So we can, with our technology, have a really good sense of when you're going to eat. And we can confirm that with some gesture control technologies that come from a wearable like a Fitbit or an Apple Watch or something like that, that tell us and can confirm that somebody's eating. So in that instance, you could, for example, remind people if there's been no bolus given that it's time to bolus. And if you miss just 2 boluses a week in a meal, that equates to about a 0.5 point increase on the A1C. So obviously, outcomes can be made better, but the important thing there is that it's done in a sort of an invisible way or a helpfully in the background way, where you're not asking somebody to do any more, which I think is really the sort of driving principle behind what Companion Medical set out to do with InPen, is make this least burdensome as possible while we can add a lot of technology that is invisible to the user for the most part, but it can really drive a better experience and better outcomes. So what we're trying to do with a closed loop, we can bring to this open loop, as I said, and that's really, I think, how the two fit together. It can help in a lot of ways.
A couple of questions about what you just said. You mentioned the gesture technology. That's Clue, right? You all acquired Clue this year, last
yes,
year?
Exactly.
We covered that.
Exactly.
Is that going to be part of a companion medical system?
Yes, so the idea is we're going to have that for any means of insulin delivery, right? So it's the ability to detect that somebody is in the process of eating and the absence of any kind of bolus is a great opportunity to say, here, let me give you a helpful tip here and remind you to bolus, whether you're pushing a button on your pump or you're reminding yourself to bolus. We can drive some improvement there. And Clue was evaluated in a recent study that we did. It's a small study, but we showed that we could, in fact, drop A1C by a fairly sizable amount just by bolus reminder. Now, ultimately, I think we can use Clue and that technology in a way that can actually automate the delivery of a bolus, so nobody has to do anything within a sort of closed-loop system. But that's some more work that we're endeavoring to do.
I'm sorry.
But absolutely, it fits.
You heard me laugh because just by bolus reminder, parents around the world of children with type 1 diabetes would argue with you that a simple bolus reminder in the form of a parent does not make that much of a difference.
Yeah.
But I hear you.
Well, I think
Good.
Yeah, I mean, the difference here is the bolus reminder isn't just it's time to bolus. What we can do, knowing the history of how much insulin's on board, get a quick estimation of medium, small, large amount of carbohydrates being consumed. We can tell you how much to bolus, not just that you need a bolus, right? Which we think is a helpful insight.
You can also smack them in the back of the head. When you talk about Clue, it also makes me laugh. As you listen, as I talk about Clue, we did an episode with them in the past, if you'd like to learn more. And Sean, I laugh because every time I talk about Clue, I do the gesture of eating food. I don't know why. You can't see me, but every time I mention it, I think that's because that's how it was explained to me when they first demonstrated it. It's a really interesting technology, but that'll be in not just pens. You're planning on using that in pumps as well?
Yeah, so Clue actually runs on a wearable, and then it talks to the algorithm that's either on your phone for your pen, or it can be the algorithm that's driving the automated insulin delivery system. So think of it like a sensor, and this sensor gives input so that the algorithm knows what's happening, and it lends itself to any means of insulin delivery.
One of the big concerns, and you know this, when a large company buys or acquires a small company or product, the big concern is that, it'll be shelved or there will be big changes to make it more proprietary. The InPen is now used with Dexcom and the Eversense implantable CGM. Can you reassure people who are using it right now that you're not going to change that? I assume it'll be used with a Medtronic sensor, but will you continue with the sensors that it is integrated with right now? All right back to Sean answering that question. But first, Diabetes Connections is brought to you by Gvoke HypoPen. And almost everyone who takes insulin has experienced a low blood sugar. And that can be scary. A very low blood sugar is really scary. That's where Gvoke HypoPen comes in. It's the first auto-injector to treat very low blood sugar. Gvoke HypoPen is pre-mixed and ready to go with no visible needle. That means it's easy to use. In usability studies, 99% of people were able to give Gvoke correctly. I'm so glad to have something new. Find out more. Go to diabetes-connections.com and click on the Gvoke logo. Gvoke should not be used in patients with pheochromocytoma or insulinoma. Visit gvokeglucagon.com/risk. Now back to Sean talking about Medtronic's plan to continue InPen with its current partners.
Yes, look, we have no plans to take away anybody's sensors from them, but we're not entirely in control of that. So if Senseonics and Dexcom plan to maintain that access, then then we're game. We want to make sure that people have the support they need.
When you say you're not in control of it, you're talking about what Dexcom and Eversense would do. You're not talking about something on your side.
No, so the way all this works is, you have to have, depending on what platform of phone you're dealing with, you have to have a thing called an API, which is basically a hook of software into the algorithm. So somebody decides they don't want to have that access any longer, they can turn it off, but we're not going to turn it off. We don't have control over that. So our belief is that, if we're meeting patients where they are and they're on a Senseonics device, we should maintain that access for those patients. Of course, we want to open up access to our own CGMs, and we have a lot coming in the pipeline for CGM, which is pretty exciting. But I understand the sentiment that when a large company buys something that they want to shelf it. This isn't like big oil buying biofuel, right? No, we think we're going to bring a lot better experience to patients by combining the best of what Companion has developed in InPen with what we're endeavoring to do with things like Clue and Neutrino and a lot of other personalization algorithms that we use in the closed loop side.
So let's talk about sensors. Let's just pivot right to that. First, though, before we let this whole thing go with InPen, any timeline on integration with I assume it's with the Guardian CGM.
Yeah, so initially we'll have Guardian, but there's, we have 3 or 4 or 5 actually different generations of sensors coming, and, it's going to be compatible with everything that we develop going forward as well.
Mm-hmm. Let's talk about Guardian Connect. This is the standalone CGM. Doesn't need to be paired with an insulin pump. Tell me a little bit about the reception of that, what the plan is for it, and, who is it for?
Yeah, so I think the standalone Guardian has been sort of an on-ramp to be able to use an integrated CGM with our pump. But frankly, I think the experience that we've provided with that needs a lot of improvement, and that's what we're endeavoring to fix with the pipeline. And there's 2 parts to that. One is finger sticks, to calibrate or to confirm before dosing has required finger sticks, and that's something that we are trying to remove in the next generation. And the other one is on just the ease of putting it on. It takes a lot of over-tape and steps to insert and generates a lot of trash in the process. So all of that's problematic, and we're moving to an integrated platform where the sensor and the transmitter are all in one easy to apply 3-step, just press it on your body kind of approach. And in the interim, reducing or eliminating the need for finger sticks. That's what the near-term pipeline's about. And then longer term, we can take the size of that down even further. We're already taking about 50% of the volume down from one move to the next. We can get a lot smaller than that. We have some really interesting technology that uses something called wafer fabrication, which just means you can make very small electronics in a very highly repeatable way. So you take a lot of variation out. And then, of course, making sure that we're continuously improving the reliability and the wear life of these devices. And there's a lot of technologies we have aimed at to ensure that happens. And simple things like we spend a lot of time, money, and effort developing a patch that's going to stay there, the adhesive that won't interfere with the skin, but will stay there through very difficult conditions. And it took a lot of engineering. We actually did a lot of the work in the fields in South Florida, just, high humid, very hot heat to make sure that we would have this adhesive just right. So there's a lot going on in the CGM side of things that's pretty intriguing.
I'm curious, and this is a very specific question. These future generations, any plan to go straight from a CGM sensor to a watch? That's something that just seems to be very difficult. No phone involved in between, nothing like that.
Yeah, it is difficult, and it's difficult for a lot of reasons, including power management of how that Bluetooth connection is different than one to a phone. So I think as watches evolve and maybe that technology changes and the ability to kind of talk, a lot of this is on the kind of wearable side of things. It's not entirely just what can you do with your CGM, your algorithm. So it is more complicated than you'd think. Hopping from phone to watch takes the processing power and the connectivity that's already there. But, think of it like a highway, right? There's only so many lanes of a highway that you can drive a car on. And if the watch is already tethered to one connection by Bluetooth to your phone, you've got fewer lanes available for other connections. So that's really, I don't want to get too technical about it, but that's really the near-term challenge. But, I think there's strong interest in this. And as the wearables progress, I think we'll have the opportunity to do things like that. But right now, it's just complicated.
All right, let's talk 770G. This was approved by the FDA in August, and it's down to kids as young as 2. My understanding was for the approval. Now, pardon my take on this, and this is for all of the pump companies. I wish you guys would call your pumps something that told us more about it. I don't know if it's a medical device thing. I have this problem with Omnipod and Tandem and everybody else, but it's all numbers. So tell us a little bit about what's different from the 770G to the 670 and then to the 780. What's different about this pump?
Yeah, so the biggest difference, other than the age indication, which does, it's still indicated for people over the age of 2. I think there was some confusion at first that it's just for kids, and it's not just for kids. Yeah, so, I think that the biggest difference is really the inclusion of Bluetooth connectivity with this device. And that does a number of things. So first and foremost, it allows a person or a parent or caregiver to see the CGM and pump data on a phone. So we'd been lagging in that competency, and now that's available. It also allows the CareLink system, which is our management system of glucose, to automatically update so that you can do things like telehealth visits, right? Or if somebody's going to the doctor's office, rather than that kind of interruption of the workflow where the pump has to be connected and then downloaded, that really slows down that visit for the person that's, at the visit. It slows down the workflow for the healthcare providers. It's the ability to take that connection and then automatically upload it at your convenience without having to do anything is what that connectivity brings to us as well. And then finally, it goes the other way too. We can, when software becomes available, make upgrades. Or if you have to patch something, you know how you get that on your phone where they'll have a new version to patch up something. You can just push that over the air. So we have that capability to upgrade future algorithms without having to connect anywhere.
So just to be clear, this is like what we do with the Tandem X2. You plug it into the computer, you get the latest download, it changes the software in the pump, and then you're off and running. Same thing, plug it into
the computer. With one big difference. We don't plug into the computer. It goes over the air. Just like you can update your phone over the air today if you're changing your operating system. It's the same idea. But you can do this without having to have a computer or having to plug cable in.
Do you need a doctor's prescription for changes, or is that a change by change? I would assume it might vary.
Yeah, it depends on the change. So if you're talking about, a security patch, you don't need a prescription for that. If you're talking about moving to the next algorithm, like the difference from 770 to 780 is really an algorithm change. It's the same hardware platform. That would require a prescription.
So let's talk about the 780, which is I assume this is the next thing in the pipeline. I'm following the numbers.
Yes. So we had released the adult data for the 780G, which 80 is about the algorithm now, at the American Diabetes Association meeting this year virtually. And really, there's a couple of differences here. What this device does now is it takes the ability beyond just basal insulin, but also to bolus, where you can, in the situation where there's rising glucose, the algorithm can bolus every 5 minutes to control. Somebody maybe missed a meal bolus, or they miscalculated how many carbs they ate, for example, and blood sugar is still rising. We can predict where it's going to go, bolus it, correct it without stacking up insulin. So what all that means is we can drive better time in range when there's missed boluses or miscalculations on carb counting. So that's one big difference. The other big difference is the target that you set these to. So you can set a target, as you may know, on the 670G, the target you can set is 120. We can still set a 120 target on this algorithm, but we can also set that target at 100. And the clinical results that we showed were really clear that you could take the target lower without increasing the risk of hypoglycemia. In fact, it was a numerically lower rate of hypoglycemia. So this algorithm, I think, really gives a lot more freedom. And I think the biggest thing that we were looking for, all these are great. Time and range, we've been leading the industry and being able to provide the best time and range. But the user experience got a lot better. And that a lot of it had to do with alerts and alarms and all the things that we did. And I think, to put it simply, there was a belief as the first hybrid closed-loop algorithm out there that whenever something got awry, that you should kick somebody out of what was called auto mode and have them go confirm something with like a finger stick. Because I think the belief at the time was that, you can't trust this algorithm to take care of somebody, and a person is better off, better able to manage their diabetes than a machine. And I think that was probably a fallacy. As it turns out, the algorithm What we change here is we just aren't kicking people out. We aren't waking people up in the middle of the night to do things. The algorithm's pretty good at smoothing things out without causing any new troubles for patients. So a lot of that, I think, out of abundance of caution, safety alerts, kicking people out, asking for fingerstick calibrations was unnecessary. And we're seeing a big reduction in all of that, and very high satisfaction among the people in the clinical trial. And we've launched it in a limited way in Europe so far, and feedback has been really tremendous. This is a very big improvement over what we had been offering.
A couple of just questions for clarity, Sean. You're talking about the algorithm in the 780, right? The 770 does not have that?
No, the 770 is basically the 670 algorithm. The big difference is really that indication of age, as well as the ability to upgrade software.
If you want a pump right now that you can then upgrade when the new 780 algorithm is available, it's got to be the 770. You can't upgrade.
Yes, you're correct.
Okay. To that end, just to clarify, are there other ranges you can set? Is it totally customizable down to 100, or is it 120 or 100?
So you can choose either target, but you can adjust other settings like the carb ratio, like insulin sensitivity factor. So there's some customization that can get there. And we ran, I think, 3 clinical trials, and we're currently doing what we call a continued access study in the U.S., where we're trying to optimize those settings to make sure that we can get the very best experience for people with the pump. And I think what we've learned is there's a lot of these other settings that we can give more help to the endocrinologists to be able to set those. But right now, those settings are the endocrinologist's job to go fix. We can give them suggestions, but the user themselves can't make those adjustments as easily.
Wait, I'm confused. The endo can make the changes, but the users can't?
Yeah, so there's certain things. Again, it's about making sure that people are safe, where we could recommend changes or the algorithms can change things along the way. But there are certain settings like these carb ratios and everything else that need to be dialed in.
Yeah, but the user can do that, right? I don't have to bring the pump to my endocrinologist and say...
They can, but they should make sure that you're talking to their care team.
Got it. Yes. No. With the guidance of an endocrinologist, but you're not going to make me get a prescription to change my carb ratio. No.
I think it's just... we can really fine-tune the system, but rather than experimenting on yourself, I think we can give some help to know what are the optimal settings for you. And that's something we call personalized closed loop. Is we could do that automatically in the background without anybody talking to anybody. That's one of our future pipeline projects. We can also tell you from the history of your glucose and insulin data how you can get a little bit better precision for somebody. And I think that's what we're trying to do on the CareLink side of things. There's the ability to really dial this in the right way. I think that for some endocrinologists, that's not going to be helpful, right? They're very, very good at this. They do it all the time. And then there's others who don't really have large type 1 populations, and they could use a little bit of, I call it the teacher's edition of the textbook here to help them make sure that they're doing the best for patients.
I think that sounds wonderful. I just think, this podcast audience is a little bit different, or I shouldn't, it's a lot different. This is an incredibly well-educated audience that is going to get a pump like this and mess around with it themselves at home and see how much they can change it. In fact, as you know, part of this audience is going to physically try to probably break into the pump and see what they can do with it. So I know you can't comment on that. You don't have to comment on it. But that's why my hackles went up when you said the endocrinologist can. But I get what you're saying. For the vast majority of people with diabetes, the endocrinologist or even their general practitioner, which is a different story altogether, is really going to be the guiding hand here. Just another question. You mentioned with the 780, the change from waking people up, kicking out of auto mode, fewer calibrations. Is that really in the works in terms of fewer or no calibrations, or that's a hope for a future sensor?
No, that's absolutely in the works for the sensors. So we have a product that's completed its clinical trial. Another one is very close to doing that eliminates or vastly reduces fingerstick calibrations. And then, so it depends on the regulatory claims that we make on that specific device. And then we have 2 others in the pipeline that absolutely eliminate fingersticks altogether. Now, that doesn't mean that if you get a reading that doesn't make sense to you, that you shouldn't go confirm it with the blood glucose, and then calibrate. There's no perfect sensor. But our algorithm itself that goes into 770 cuts down by about half the number of requests for fingersticks with the same sensor. And then when we change the sensor, we can largely eliminate that unless there's something that's needs to be confirmed because the reading doesn't make sense.
So is the hope that the 780G would launch with, I hate to compare it to Dexcom, but let's just go ahead and do that, because that's what we're all talking about here anyway. Obviously, most people who use a Dexcom understand that it's not infallible. You do have to double check sometimes. You'll get a sensor error when it doesn't understand what it's getting, the information that it's taking in. It'll stop working, that kind of thing. So is the hope to launch the 780G system with a sensor that's comparable to what I just described?
So it's going to depend on where you are in the world, but the 780 is going to be compatible with past and future sensors. Mm-hmm. So, they may be on different timelines. And we're really trying to think about this like as a system too. So we've got the pump, we've got the algorithm, we've got the sensor, and the other thing we have is the tubing set and reservoir. And there's another innovation we're bringing that allows you to extend the use of that on label of that tubing set from the typical 2 to 3 days out to 7 days. We call that the extended wear infusion set. That's also been as a clinical trial, and the goal is to have that also compatible with that 780G algorithm. So the algorithm that's on that pump, which can have all that connectivity advantage, can work with this current and future pipeline of sensors and be upgradable on the infusion set, is all sort of in the suite of what we're trying to bring together.
Well, boy, am I glad you brought that up, because I have said for years, and my son has been using an insulin pump for, 13 years now, that the inset is the weak link of pumping. And I know, a couple of years ago, we were all excited about the BD flow. It was supposed to be the latest and greatest. It didn't work out so well. So that went away. Can you tell us a little bit about what you found? When I hear longer wear insets, I think, oh my gosh, we've all been warned about infection and scarring, and don't use the same site for that long. What are you finding?
No, it's a really good question. And, what is it that's so magical about it? And how do you get to extend it? And, without getting too much detail, I'd say the simple answer is that there are things that are in insulin to keep it from going bad. The preservatives, if you will, are behind a lot of the sort of site reactions that you get. So we're able to take that stuff out and have just filtered insulin, if you will, delivered to the site. And that's really the magic behind getting the extension of use. And, we did a study where we measured this, and about 80% of the study participants were able to get to 7 days. Now, your body is going to react a little differently depending on who you are. You see that with CGM, right? Where some people can wear those things for 2 weeks and other people can't because their body's more aggressive at attacking that foreign body response. Just by comparison, for 3 days, which was our control arm, 70% of people got to 3 days, right? So we've got a higher proportion of people able to make it out to 7 days. We think it's largely due to getting out those preservatives that are in the insulin to keep it fresh.
That's fascinating. It's simple as a filter. I've always thought that just not enough study was done.
No, it's also, insulin's a very sensitive molecule too. It's sensitive to temperatures, and it's also sensitive to, how it's contained in a reservoir. So our rigid reservoir system doesn't mechanically damage the molecule either. So that's, an advantage that we've always had with our reservoir design. Then you add to this the ability to filter out the preservatives, and you get this extension of wear. So you can preserve a lot of insulin, use it a little more judiciously, and of course reduce the difficulty of having to change your set every day. Maybe it's fusion set Sunday, you change it once a week, and maybe at the same time you're changing your sensor as well. Who knows?
Well, I think that would be pretty amazing to have a longer wear inset that works, because a lot of people have trouble, as you said, getting to 3 days.
Yes.
One of the big questions that came up in with my listeners when I told them I was talking to you, and we've covered most of them, but one of the big questions came up was Medicare, in terms of this technology is great, will it be covered? Can you speak to that at all?
Which part of Medicare are you asking about? Are you asking about the
let's talk,
CGM or the...
Well, I think the real question is everything, but let's talk about the system, as you mentioned. You talked about it as a system, the 780. Will the system be covered, or will it be piecemeal? Yeah,
so the rules of Medicare are really around the designation of the sensor. Can you make a claim of what's called non-adjunctive, meaning that you don't have to confirm the CGM ruling before you dose insulin. So when you're 64 years old and you're pre-Medicare and you're on a 670G system today, your commercial insurance pays for the sensors, the tubing sets, the reservoirs, and of course that initial investment in the pump. When you turn 65 and you move to Medicare, you no longer can get the Guardian sensor paid for because we don't have that designation for non-adjunctive, even though it's clearly driving the pump all day long, every day. That's just the sort of idiosyncratic rule that's there. So we have to get that labeled claim for the sensors for everything to be covered. And that's what we're trying to do right now with the Guardian sensors and, of course, the future pipeline sensors themselves. But I think it's there's a couple different efforts on that, but it is a little bit of an idiosyncratic thing that exists in Medicare itself, just the way the payment law works. And we're trying to get that changed.
Has COVID delayed studies, submissions, things like that for you all?
The branch of the Food and Drug Administration that regulates the diabetes space is also involved in a lot of things COVID-related, including like the in vitro diagnostic testing and that sort of stuff. So yes, I'd say on the medical reviewer side in particular, there's been just a difficulty for them to service all the kind of pre-market or new devices that are coming through while doing this, difficult work of making sure that all the COVID tests and things related to that are done. So yeah, there's been something that has been a little bit challenging. And of course, in the clinical trial environment, we actually had a couple of trials going on during COVID, and some of them have gone pretty well, honestly. I think people are stuck at home and willing to participate in the trial. It's not been like that in other parts of Medtronic. We've got a lot of the hospital-based studies have been very difficult and highly impacted by, understandably, people's fear of going to a hospital for anything right now is pretty high. So I'd say it's been a mix. Like we've had really good collaborative conversations with FDA, making sure that we streamline and make it as simple as possible as we submit new dossiers. But there is really a constraint at that medical reviewer level that's been difficult for the entire industry.
You've been so generous with your time. I really appreciate it. I just have one more question for you here, and that's about Tidepool. About a year ago, maybe more now, Medtronic and Tidepool announced that they'd be working together on a future interoperable closed loop, and it would be a separate system from the 780. Any update on that?
Yeah, we're continuing to work with Tidepool. There's a joint steering committee that we participate in. Our goal here is to create a ACE-designated pump that runs the Tidepool algorithm. But that collaboration is ongoing. We're working well with them, but I don't really have an update beyond that.
Well, Sean, I really appreciate it. There's so much going on, to talk about. Thanks for keeping us straight with the numbers and everything else. I hope you come back on and, continue to explain all of these developments. But I really appreciate it. Sean, thank you so much for spending so much time with me.
Appreciate the opportunity. Thank you, Stacey.
You're listening to Diabetes Connections with Stacey Simms.
We talked about a lot of stuff there. There is a lot more information, as always, over at diabetes-connections.com. You can learn more on the episode homepage about everything that Sean talked about. I'll link up some stuff to Medtronic and to some other studies. I said a couple of weeks ago, there's something about September, October. It's like all summer long. Yeah, we have the ADA and we have the different conferences. But then every year at this time, I feel like, it's kind of slow. Nothing's happening. And then I get all the tech companies in the fall. So I'm excited to continue to bring you as much information as I can. I have more interviews coming up. We just talked to Dexcom. I'll also be talking to Abbott. I'd love to get Omnipod, the folks from Insulet, back on here. So we'll see what we can do. But in the weeks to come, definitely let me know if there's particular technology you want to hear more about. I love talking to these companies. It's always fun to get a kind of a peek under the hood. And I like hearing the voices and the stories of the people who are in charge of this stuff. I appreciate them coming on. Not everybody does, you know that. But it's great when they can answer your questions. And I love doing that. So let me know who you want to hear from and let me know what you want to know. All right, innovations in just a moment with that once-a-week basal insulin that's being tested. We'll talk about that. But first, Diabetes Connections is brought to you by Dexcom. And when you have a toddler diagnosed with type 1, you hear rumblings for a long time about the teen years. When it hit us full force a little early, I was so glad we had Dexcom. Benny's insulin needs, I've shared this, they started going way up around age 11. And when I say way up, I know some of you parents out there with little ones think maybe we increased by 0.2 or something like that. Because I remember those days. Benny's first basal rate was 0.025. That's how much basal he got an hour. But by the time, between ages 10 and 12, his basal rates doubled. And between 12 and 13, they doubled again. So along with the hormone swings, I really can't imagine managing diabetes during this crazy time without the Dexcom continuous glucose monitoring system. We can react more quickly to highs and lows, see trends, adjust insulin doses with advice from our endocrinologist. I know using the Dexcom G6 has helped improve Benny's A1C and overall health. And by the way, he's almost 16 and those insulin needs have already started going down. This is wild. If your glucose alerts and readings from the G6 do not match symptoms or expectations, use a blood glucose meter to make diabetes treatment decisions. To learn more, just go to diabetes-connections.com and click on the Dexcom logo. Innovations this week, a once-weekly basal insulin. This is something that was announced earlier this summer. I don't know about you, but it snuck by me. It was announced at the ADA Scientific Sessions. Novo Nordisk announced that a once-weekly insulin, Icodec, had performed as well as Lantus in a 26-week trial. Now, this particular study was done with people with type 2 diabetes. But before you dismiss it, there has already been a trial of people with type 1 diabetes, and Novo expects to submit and get this, hopefully FDA approved, for people with type 1 and type 2 diabetes. I couldn't find a lot of information about the previous trial with type 1. There is another one that completed over the summer. Hopefully they'll release the information on that. Maybe some of you who are more savvy in the ways of clinical trials can dig it up. But can you imagine once a week basal insulin? I mean, obviously the benefits of that would be incredible. I'm also thinking about it for people who like to go untethered, using basal insulin from an injection along with an insulin pump, which is something we did for 2 years. And even with Control-IQ and, more advanced hybrid closed loops, we were just talking to Medtronic about theirs, I know a few people who like to use untethered with it, who find that there's just something about getting that always constant, steady basal insulin smooths everything out. And certainly when you get into the enormous elephant doses that Benny was taking for a while, it helped tremendously to take that load off of the pump. I mean, between his weight loss and coming out of puberty, and I know he loves when I talk about this stuff, his insulin needs have come down incredibly, and certainly to the point where we didn't need to stay on untethered. But I think it's fantastic. It's a great option to have. And once a week basal insulin would make that a lot better. So I will keep you posted if I find out more about the type 1 trial. But it is called Insulin Icodec. If you have something for innovations, please let me know. This can be a hack that you've thought up, a tip or trick, something with technology or new insulins. You can always email me, Stacey at diabetes-connections.com. I mentioned Benny's 504 review earlier in the show, and that happens later this week. He's also got an endo appointment this week. Lots going on. I don't think the endo appointment's going to be too exciting, hopefully, but, we do check in every quarter. And I think to mix it up, my husband is going to take him this time. Slade rarely goes to the endo, usually because he's working and busy, and it's been on me for the last couple of years, which I love to do. I really like catching up with our endocrinologist who's become a friend. But I think I'll let the boys go. And gosh, another reason not to go. I'm looking at making sure my door is closed so Benny can't hear me. The kid has his permit, and he's going to be getting his driver's license if he passes in January. And I know Slade will let him drive to Charlotte, which is like a 40-minute drive. So he can do that. I don't need that stress of sitting in the front seat and putting the mom seatbelt, right, throwing my arm out, which I cannot believe I do, but I've done it with both of my kids. Oh, I remember my mother doing that clear as day. I don't even know if they're doing driving tests here. They haven't been. I know plenty of kids who got their licenses this year. Because of COVID, they're not actually giving them a driving test. They're just saying, oh, did you do your hours? All right, here's your license. And it's a graduated system here in North Carolina. So they can't get there after 9s. They can't drive at night until they take an actual driving test. But oh my goodness. All right. So lots to keep you posted and updated on next week. We'll see how much Benny lets me share. Thank you so much to my editor, John Buchanan from Audio Editing Solutions. Thank you so much for listening. Don't forget, if you want the free audiobook, email me, Stacey at diabetes-connections.com, subject line audiobook, and the first 2 will get that promo code. Thanks so much for listening. I'll see you back here next week. Until then, be kind to yourself.
Diabetes Connections is a production of Stacey Simms Media. All rights reserved, all wrongs avenged.